Immune Thrombocytopenic Purpura, ITP for short. It might sound a bit dense, maybe intimidating at first, but it tells this remarkable story about our immune system, sometimes making a really big mistake.
Yeah, and what's truly insightful here, I think, is how understanding the details of something like ITP, it goes way beyond just facts. Our mission for you today isn't just to explain the causes, diagnosis, management. It's really to equip you with the why, the deeper reasons behind it all, so you feel genuinely informed. We'll look at how the body's own defenses can sort of turn against itself, specifically with ITP.
Absolutely. So let's lay the groundwork.
Right.
What exactly is ITP at its core? You hear immune thrombocytopenic purpura. Sounds like a mouthful, right? But each word tells part of the story. Immune, that tells us it's autoimmune. Your immune system gets confused. It mistakenly flags your own healthy platelets as invaders.
Which is a huge deal, really. A case of mistaken identity by your own body.
Exactly. Then thrombocytopenic, that just means a low platelet count.
Yeah.
Thrombocytopenia.
Yeah.
And purpura, that's the bruising, you see, those purple spots, because you don't have enough platelets for normal clotting.
Simple when you break it down like that.
Yeah. And here's where it gets really interesting. The incidence. Who gets this? It's not random. We see ITP more often in children. And there's this fascinating link. It often pops up right after they've had some kind of virus.
Like a common cold or something similar.
Could be. But then in adults, especially women, it tends to be chronic, long-term. It can come and go. So right away, you've got these two very different pictures for the same basic disease. Makes you wonder why, doesn't it?
It really does. And if we connect this to the bigger picture of autoimmune diseases, well, the immune system messing up is kind of the central theme, right? But ITP is striking because the platelets is so specific. And like you said, these really distinct age patterns. In kids, maybe it's just a temporary blip, an overreaction. In adults, it suggests something maybe more ingrained is going wrong with the immune regulation. Understanding that difference is key for how we approach it.
That's a critical distinction, definitely. So let's dive deeper into the how, what's actually happening inside at the cellular level. This gets us to the pathophysiology, the nuts and bolts. It involves specific autoantibodies, mostly IgG type. Think of them like, I don't know, rogue security keys. They're not just attacking randomly. They target really important proteins on the platelet surface, glycoproteins specifically. GPI, BIA, and GPI are the main ones, like little ID badges on the platelets.
And these faulty antibodies basically stick to those ID badges, right? Tagging the platelet.
Exactly. They mark them for destruction.
Okay, so what happens next once they're tagged?
Well, that's where specialized immune cells called macrophages come in. Think of them as the cleanup crew.
Ah, right. The immune system's disposers.
Yeah. They see these antibody-coated platelets, recognize them as bad or damaged, and boom, they destroy them. And this destruction happens mostly in the spleen.
Which raises an interesting point. The spleen's role, it's not just filtering blood, it's actively involved in this immune process, this regulation.
Absolutely. The spleen is kind of ground zero for this destruction. It's super efficient at pulling out those tagged platelets. But, the body isn't just sitting back, it tries to fight back. In the bone marrow where platelets are born, the megakaryocytes, those are the giant cells that make platelets that go into overdrive.
Trying to compensate, right, make more platelets.
Exactly. They're trying to pump out platelets like crazy to make up for the ones being destroyed. But the destruction happening out in the blood, mainly in the spleen, it just outpaces production. The numbers still end up low. It's like trying to fill a leaky bucket, a constant uphill battle for the marrow. Okay, so moving from the how to the what you see. If someone has ITP, what are the actual signs, the clinical features? The classic ones are petechiae, these tiny pinprick red dots under the skin. They look a bit like a rash, but they don't fade when you press on them.
Right, because it's actual tiny bleeds under the skin.
Precisely. Then there's purpura. Those are the bigger bruises, sometimes really noticeable, that seem to appear out of nowhere without a big injury. And you might also get mucosal bleeding, these like nosebleeds that are hard to stop, or bleeding gums when you brush your teeth. Sometimes more serious internal stuff, too, if it's severe.
And here's something fascinating, clinically speaking. The absence of a symptom can be just as telling as the presence of one. You might expect the spleen to be enlarged, splenomegaly, right? Because it's so involved. But usually in ITP, it's not enlarged.
That seems counterintuitive. Why is that important?
It's crucial for diagnosis. It tells us the spleen's main job here is destruction, clearing out tagged platelets efficiently. It's not getting bigger because it's being infiltrated by abnormal cells or overproducing cells itself, which is what happens in things like leukemia or lymphoma. So A normal-sized spleen actually helps point towards ITP and away from those other conditions.
That's a really sharp diagnostic point. And again, thinking about those clinical signs, the age difference matters hugely. We mentioned kids often post-viral, often self-limiting. It just goes away on its own, maybe weeks, maybe months. Their immune system kind of resets.
A temporary overreaction, essentially.
Yeah. But for adults, it's usually that chronic relapsing pattern. It can flare up, settle down, flare up again, suggests a more stubborn, persistent immune issue. And that difference totally changes how you think about managing it long term.
All right, so let's say these symptoms appear. How do doctors actually confirm it's ITP, the diagnostic journey? It usually kicks off with a blood test, right? Looking for that low platelet count. The main number they look for is generally below 100,000 per cubic millimeter.
That's the initial flag, yes. But it's just step one. You need more detail.
So what's next?
A peripheral smear is vital. You take a drop of blood, put it on a slide, look under the microscope. It confirms the low count, sure, but critically, it shows the morphology, the shape and appearance of the platelets that are there. In ITP, those remaining platelets usually look normal, healthy, just fewer of them.
And why is that important that they look normal?
Yeah.
Because it helps rule out problems where the platelets themselves are faulty or where the bone marrow isn't making them properly in the first place, like certain genetic platelet disorders or bone marrow failure syndromes. If the platelets look normal, it points towards destruction rather than a production issue.
Got it. Makes sense. And sometimes you need to go even deeper, right? Like a bone marrow examination.
Yes, sometimes that's necessary to really clinch the diagnosis and rule out more serious things. You take a small sample of bone marrow, usually from the hip bone.
And what are you looking for in the marrow?
You're looking at the megakaryocytes, those platelet factories. In ITP, you typically find an increased number of them. Seeing lots of megakaryocytes in the marrow, even though the platelet count in the blood is low, is a really strong sign. It confirms the marrow is working hard, trying to produce platelets. The problem isn't the factory, it's the destruction happening elsewhere. This helps rule out things like aplastic anemia or leukemia, where the megakaryocytes might be decreased or look abnormal.
So what this all means, really, is that diagnosis isn't just about spotting low platelets. It's about figuring out why they're low and meticulously crossing off other possibilities.
Exactly. Exclusion is a huge part of it. You have to rule out what we call secondary causes. Things like infections, HIV, hepatitis C can sometimes cause low platelets. Other autoimmune diseases like lupus, even certain medications, they can all mimic ITP. So it's like detective work. You eliminate the other suspects until ITP is the most likely culprit left standing.
Okay, detective work done. ITP is diagnosed. What's the plan? How do you treat it? Seems like strategies would vary a lot based on the person and how bad it is.
Absolutely. It's very individualized. Sometimes the first step is doing nothing. Observation.
Really, just watch and wait.
Yeah, for mild cases.
Okay.
If the platelet count is, say, above 30,000 and there's no significant bleeding, especially in kids where we know it often resolves on its own, why jump in with strong medicines if you don't have to? For adults, too, if the bleeding risk seems low, you weigh the risks of treatment versus the risks of the condition itself.
Makes sense. But if observation isn't enough, or if things are more serious, what's the first line of attack?
First-line treatments usually involve either corticosteroids, prednisone is a common one, often dosed at 1 milligram per kilogram of body weight, or something called intravenous immunoglobulin IVIG. Corticosteroids work by basically dampening down the whole immune system, reducing that attack on the platelets.
Okay, suppressing the attack. What about IV? How does that work?
IV is interesting. You give a large dose of pooled normal antibodies intravenously. It doesn't directly stop the production of the bad antibodies. Instead, it sort of distracts the macrophages. Remember the cleanup crew?
Yeah, the ones eating the platelets.
Right. IVG floods the system with so many normal antibodies bound to other things, the macrophages get busy clearing those out. They become temporarily overwhelmed or diverted, and they lay off destroying the platelets for a bit. It gives the platelet count a quick temporary boost, like creating a diversion.
Ah, a diversion tactic. Clever. Okay, so what if those first-line treatments don't work well enough?
Yeah.
Or stop working, those refractory cases?
Then you move to second-line options. These might include drugs like rituximab. Rituximab targets specific immune cells, B cells, which are responsible for producing antibodies. So it tries to shut down the factory making the rogue antibodies. Or another major second-line option is splenectomy, surgically removing the spleen.
Removing the spleen, that sounds pretty major.
It is a significant step, and it's irreversible. But remember, the spleen is the main site where those tagged platelets are destroyed. So removing the spleen gets rid of the primary battlefield. It can be very effective for many people, but it does come with lifelong risks, like increased susceptibility to certain infections.
Right, not a decision to take lightly. What about emergencies, like severe, life-threatening bleeding?
For those critical situations, you need a fast, aggressive approach. It's usually a combination. Platelet transfusion to get the numbers up immediately, plus IVIG for that rapid immune diversion, plus high-dose steroids to suppress the immune attack broadly. All hands on deck to stop the bleeding and stabilize things quickly.
And just circling back to kids quickly, the approach is often different there, right?
Yeah.
Because it tends to go away.
Exactly. Since spontaneous remission is so common in children, especially after a virus, the default is often to manage supportively and monitor closely. Unless the bleeding is really severe or persistent, you try to avoid potent treatments like long-term steroids or splenectomy if possible, giving your system a chance to recover naturally.
Okay, so looking ahead, prognosis, lifestyle, what's the long-term picture for parents listening, maybe worried about their child? Sounds like there's good news.
Yes, definitely. For children, the outlook is generally excellent. Most kids with ITP recover completely. No long-term consequences from the ITP itself. They live totally normal lives.
That's great to hear. What about for adults, where it's often chronic?
For adults, because it is often chronic and can relapse, it usually means needing long-term follow-up with a hematologist or their medical team. This really brings up the importance of ongoing patient education and self-management, understanding your own ITP, knowing your triggers if you have them, tracking symptoms, communicating effectively with your doctors. It's about being an active partner in managing the condition.
Absolutely. And are there lifestyle things anyone with ITP should keep in mind?
Yes, definitely. Avoiding medications that increase bleeding risk is crucial. That means things like aspirin and NSAIs, ibuprofen, naproxen, that kind of stuff. Unless your doctor specifically says it's okay, they can make platelets less effective. And just general precautions to avoid trauma. Being careful with activities that could lead to bumps, bruises, or injuries because bleeding can be more significant.
Makes total sense. Well, this has been a really thorough deep dive into immune thrombocytopenic purpura. We've gone from defining its autoimmune roots, looking at the cellular battleground through the diagnostic maze and onto the treatment strategies. I think the clear takeaway is that getting that early, accurate diagnosis and finding the right tailored treatment plan is just so vital for managing ITP effectively, helping people navigate it and maintain their quality of life.
Absolutely. And as you think about everything we've covered, here's a final thought to maybe mull over. Isn't it fascinating how the body has this incredible ability to adapt and compensate, like the bone marrow ramping up megakaryocyte production? But at the same time, that compensatory mechanism is clashing with the immune system's own highly specific yet misguided attack. What does this sort of internal conflict, this delicate, sometimes paradoxical balance, tell us about the sheer complexity needed for health? And the constant tightrope walk our immune system performs every single day. It's really quite something, even when it goes slightly wrong.